Donc, le professeur Guy Meyer qui
Professor Guy Meyer is at the most beautiful hospital in the universe, the Georges Pompidou Hospital, and he's a thrombosis expert. And on a regular basis, he does us the honor of coming over and discussing this major aspect in cancerology. And as far as I'm concerned, he has been an invaluable support, an invaluable leader, both in a hospital setting and elsewhere. Wow. After such an introduction, it's a tough act to follow. How could I possibly keep up with your expectations? My disclosures, I work with all pharmaceutical companies that manufacture anticoagulants. I didn't get rich in the process, but they basically support my research, my academic research. We always say that thrombosis is the second leading cause of mortality in cancer patients. Seriously, let's be modest. We're not as good as oncologists. Nowhere near as good. The leading cause of death is cancer itself, isn't it? And thrombosis, we're small-time players. We're small fry. Less than 10% of cancer patients die because of us. So if we look at the different series, in terms of incidence, the series that is the best documented at the end of the day is from Vienna. That is the first one I'm showing you. This is a study with a majority of solid tumors with prospective follow-up. So we're talking 7 or 8% with a follow-up time of 18 months, roundabout. Approximately 18 months follow-up. These are the figures. So 5% a year. We're not far from the truth, but huge changes, huge differences from one cancer to another. As you know, there is a predictive score for thrombosis. It was developed by Corona, and there are 6 different variables, including the cancer site, actually 5 different variables. Platelet count should be in excess of 350, hemoglobin under 10 gram, leukocyte count, and the BMI. Now, we did not include the history of thromboembolic events. I find that surprising. But some of the data we don't have. In any case, it works rather well. When you find that the risk of thrombosis at 3 months is lower than 1%, 2 points means 2%, and 3 points or more. As you can see, this collective accounts for 15% of the derivation population, and the risk is 7%. So venous thrombosis or pulmonary embolism. So we're able to select the highest risk patients. The problem is, up until now, the trials that tried long-term prophylaxis selected patients who had the locally advanced metastatic cancer, irrespective of risk score. And so we end up with trials that show a significant difference, a reduced risk of events of 50%, but only 4% in the control group. So it may be a significant difference, but there are too many patients to treat in order to avoid a thrombosis, which means that we're not doing the line. And the second study shows the exact same thing with a different type of heparin. A risk reduction higher than 50%, but once again, the risk is much too low in the control group, which means that the absolute risk difference is too little in order to treat those patients using a monthly injection of heparin. There is one cancer, however, for which we have more solid data. Advanced pancreatic cancer. Here we have 2 trials. Careful. These people have advanced pancreatic cancer. They receive chemotherapy, no thrombus. And if we look at the doses of Deltaparin, no prophylaxis, those are curative doses. So when we do that, yes, of course, the risk is reduced significantly so, 50%. But here again, we're basing ourselves on a much higher baseline in the order of 28% for all thromboses, so 22% for asymptomatic thrombosis, so about 9-10%. So a risk reduction of 50%, but the absolute reduction is here very high in these advanced pancreatic cancer patients. Once you stop the prophylactic treatment, the thrombose reemerges. Another recent trial, which came out in your favorite publication, Enoxaparin. Here again, this is not a prophylactic doses. It is half of the curative doses administered for 3 months and then a prophylactic dose. And here again, we find a reduction from 15 to 5%. This is a significant reduction in risk. So both relatively and also in absolute terms. And here again, lots of bleeding in the placebo arm, 8% under enoxaparin and 7% in the placebo arm. So the difference is not significant. I'm a bit surprised by this bleeding rate. So for pancreatic cancer, we have a little more solid data. Lung cancer, there are trends. These studies are ex post. They happened after other major studies. So we have a little bit of information, but it's not very robust. So the guidelines. As far as ISTH is concerned, the international oncology guidelines are pretty close. We're being told don't do prophylaxis. It's not recommended routinely. Yes, you can consider it for advanced pancreatic cancer patients receiving chemotherapy and with a minor risk of bleeding, and also maybe with patients with locally advanced or metastatic lung cancer. A number of trials are about to begin, cancer by cancer, because I think that looking at every single cancer at the same time is probably not a good idea. So that's what I wanted to tell you in terms of prophylaxis. And this is something that you know by heart by now. In 2003, Agnes Lee, the CLOT study comparing vitamin K with deltaparin. There's a 50% reduction in thromboembolic events. This is a significant reduction, statistically speaking. It's high in absolute terms. We go from more than 15% down to 7% in the deltaparin group. We also expected a reduction in bleeding. Didn't happen. From a numeric point of view, there's a little more bleeding under deltaparin as opposed to warfarin, but the difference is not significant. But we didn't see any more. So the results were just confirmed by a more recent study. Same author. Here we're looking at tinzaparin, 2015. These are patients who are probably less severe. The risk reduction is 65%. As you can see, this is not significant, probably because the study is underpowered. Contrary to what we saw in the CLOT study in 2003, AVKs lead to just 10% of complications, but tinzaparin leads pretty much to the same result as deltaparin in 2003. So probably here we have less mets, the patients are less severe, which means that the AVKs are doing better now than before. This is not going to challenge the questions. There will be meta-analysis, and we'll still have 45% of risk reduction. Good news in the second study is that there's a little bit less bleeding under tinzaparin. This is not something that we saw in the CLOT study. Still no difference in terms of mortality. There's probably no reason to administer low molecular weight heparin to reduce cancer mortality. So here, a 50% risk reduction for thromboembolic events, no risk reduction for bleeding. We expected it, it didn't happen. And by way of conclusion, there are limitations in terms of prolonged low molecular weight heparin. We need daily injections. It's expensive. And it's also difficult to use this beyond 6 or 9 months because the patients want tablets that they can take by mouth. Also, we've been told that this is better than AVKs. Yes, but there's still lots of different troubles. In other words, there's still room for improvement. Can we settle for 5 to 7% relapse rate? Can we be happy with that? The bleeding risk of 5 to 7%, not lower than AVKs. So there's still room for improvement, probably. So direct oral anticoagulant. You take them by mouth. It is the same dose for everybody. Very few drug-drug interactions, so why not use it for cancer? But in the major studies that compared direct oral anticoagulants with VKAs, we compare more than 500 cancer patients. And as you can see, the risk reduction is not very significant, 40%, but the hazard ratio, the odds ratio is 0.1. So there's a trend, but it's not significant in terms of relapse. For bleeding, as you can see, there's a trend. Risk reduction, close to 25%. Again, not significant. Careful, we're not comparing ourselves with low molecular weight heparin. We are comparing ourselves with VKAs. And what should really jump out is that the risk under VKAs is weak. So yes, these patients have cancer, but they've been selected. And so when we compare EINSTEIN study with the CLOT study and CATCH study, only 22% of these patients are metastatic, whereas in CLOT and CATCH, we have 50% metastatic patients. Only 13% have received cancer treatment, even though they are the majority. And with regard to AVKs or VKAs, it's much more administered with EINSTEIN, which basically means that these patients have been carefully selected. They've been cherry-picked. So, yes, these anticoagulants may do better or not better than VKAs. In other words, there's room for improvement and more work. In terms of routine long-term prophylaxis, a number of studies are underway, and they should be helpful for specific cancers. We should decide whether or not it's interesting. With regard to treatment of thrombosis associated with cancer, yes, LMWH remains the preferred therapeutic option, the first line of treatment, and should be administered for at least 3 to 6 months, and then it's on a case-by-case basis. These results are supported by the CATCH study, which has 1,000 patients more. Now, the optimal treatment option after 6 months must be adjusted, must be adapted. Now, trials are about to begin. You'll get the results in 18 months. Right now, we're doing the trials, which means that we don't have the results yet. We need to wait until the end of the trials before we can start using direct oral coagulants for these patients. Thank you.